And welcome to JPR in beautiful Sao Paulo, Brazil. John Sabol, Clinical Research Manager for Konica Minolta Healthcare Americas. And I'm here with Dr. Hussain, and we're going to talk about DDR for the shoulder.
Perfect. Thanks, everyone. Thanks for inviting me. My name's Zaamin Hussain. I'm at Emory University in Atlanta, Georgia in the USA. Also delighted to be here in Sao Paulo. I'm very excited to be talking to you about dynamic imaging of the shoulder and how dynamic digital radiography is changing the diagnostic paradigm. You ready for me to get started?
Go ahead.
Great.
Looking forward to hearing what you're saying.
So dynamic digital radiography is a novel technology that we use in our clinic at Emory, and it's transforming our understanding of how patient disease manifests and is diagnosed, and also helping us to evaluate how our interventions, operative and non-operative, are helping patients and allowing us to actually make diagnostic decisions. It uses a series of low-dose pulsed radiographs acquired at around 15 frames per second. And by doing that, it allows us to observe dynamic joint motion, as I'll go on to talk about. So in the way that we acquire these images, it's 6 or 15 frames per second. The exposure time typically that we use is around 8 to 10 seconds, but it can take up to a maximum of 20 seconds. It includes a very large field of view relative to other imaging technologies. It has been FDA cleared and it's reimbursed as cine radiography. Typically, we view it on the PAC system and we're able to scroll through the loop, showing the dynamic motion. And crucially, the dosage of the DDR series is 1.3 times a standard X-ray. And when we look at other imaging that's done around the same, different parts of the body, it's 8% of a chest X-ray, and in a shoulder, it's less than 1% of a shoulder CT. So that is a substantial reduction in the amount of radiation, given how much additional information we're getting from a static X-ray. So some people say, how is DDR different to fluoroscopy? And a number of ways, really. So firstly, it's easy to perform. From a clinical workflow point of view, we have trained technicians who are performing these studies without the physician needing to leave their clinic to do these studies. It's also recordable, which allows us to do a lot of research. The fact that we can go back after these patients have left and actually analyze the images and make measurements, as I'll go on to talk about in a little bit. It gives us the flexibility to choose exactly how we're going to be taking these images, what part of the body, what motions. It includes a large field of view, typically 17 inches by 17 inches. And the radiation dose is low, and it also, as we've discussed, incorporates a dynamic component. So for example, in the cervical spine, you can see how beautiful these images are that are giving us a lot of information that are helping with diagnosis and management of these disorders. You have lateral views, AP views during rotation, and also oblique views. And all of this information combined is helping us treat these patients. We've also used it in the lower extremity. You can see that it can be helpful in the hip, in the foot and ankle, especially after an ankle injury. You could see that there's a lot of displacement, and also helping with knee pathology during flexion and extension of the knees. In the upper extremity, it's helping us evaluate wrist problems, elbow problems, and also after surgery, helping us to know if the patient has stiffness, if they have adequate range of motion, and if the fracture that we fixed has now healed. But I think the most that we've used it in is the shoulder, and that's where a lot of my research lies with the research team. So the shoulder is an incredibly complex joint. It includes 4 different smaller joints. It includes the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, and the scapulothoracic articulation as well. And all of this combined allows us to establish the excellent range of motion that the shoulder has. But when you have a pathology, we don't exactly know where that pathology might lie, and DDR is helping us to really discern where the problem is, and therefore how we can treat the problem. So typically in shoulder DDR, we're getting Gracie views and shoulder axillary lateral views, and doing various motions in these positions, and we think that that gives us the most information from a typical DDR sequence. This is a normal asymptomatic shoulder. During abduction, you can see a good Gracie view. The joint space is well maintained. You can see on the axillary view, the joint is concentrically reduced, and it's stable within the glenohumeral joint. So all of this information combined is helping us to assess the shoulder when pathology arises. So I mentioned that we also started to do research, measurements, and one thing that we're really interested in that is helping us a lot is the scapular-humeral rhythm. And classically, we always thought that the scapula contributes about 1/3 of the motion of the shoulder, and the rest it comes from the glenohumeral joint. And the way we really tested that was by doing a measurement called the scapular-humeral rhythm, which took the ratio of the change of humeral motion by the change in scapular motion. Now, DDR is really allowing us to examine whether those classical narratives are holding true in normal patients, but also how they change when patients have shoulder problems. And we have actually just published a study this year that investigated this and how the scapular-humeral rhythm was actually different depending on the type of pathology. And this is also showing us that there is a role for DDR in actually helping with the diagnostic process, so that before the patient is even seen us in clinic, we have the DDR imaging available, and we can already start to predict what the diagnosis of that patient is before we even see them in person. And that's what really makes this a novel diagnostic tool. So classic, we started making manual measurements. Typically, we're doing this at 30 degrees, 60 degrees, 90 degrees of humeral abduction, and also measuring how the scapula is changing, and that's getting us our scapular-humeral rhythm. Now, there are various settings, various pathologies that this is incredibly helpful, and one of them is in the scapular disorders. We know that in the scapula, it's an incredibly complex bone because there's so many muscular attachments, and it moves in a very interesting way, and it's confused orthopedic surgeons for several decades now, mainly because of the role of the periscapular muscles. We know that the trapezius has a large insertion, the rhomboids, the levator scapulae, serratus anterior, pec minor, all attached to the scapula and work in a coordinated way. And it's easy for that coordination to be disrupted. For example, in this patient, they're unable to elevate the shoulder past around 100, 110 degrees because of a primary scapular pathology, and we can see that the abnormal motion of the scapula. In this patient, it's very similar. Trying to elevate her left arm, the scapula is moving abnormally, but it's very challenging from an examination point of view to understand the true cause of this scapular pathology, and I think that's where DDR has an incredibly important role. For example, on the image on the left here, you can see that the scapula is totally paralyzed. It's not moving at all. It's not externally rotating like a typical scapula would upon humeral abduction. On the image on the right, you can see that the scapula is protracted. It's moving in a dyskinetic pattern, and it's again not allowing the humerus to be abducted because it's impinging on the acromion just above it. And this information was previously not available with the DDR, before DDR. So when analyzing this, we decided to compare these different groups. Firstly, in normal patients, you can see a nice external rotation of the scapula. We took 21 of these patients who are asymptomatic, normal shoulders. We compared this to patients with serratus anterior paralysis that was diagnosed on clinical examination and EMG. Again, where you can see the scapula is totally paralyzed. We also compared it with patients with scapular dyskinesia. And we found that upon taking the scapulohumeral rhythm, we're using 2 trained readers for the assessment tools, we found that the scapulohumeral rhythm was actually different between the different patients. It was 2.18 in normal patients, massively elevated in serratus anterior paralysis, purely because that scapula is totally paralyzed. And in patients with scapular dyskinesia, also elevated because of that abnormal motion. And when we were looking at this in a box plot, a lot of outliers where the patients have paralysis in the serratus anterior group. And when we distributed this on a normal distribution by taking a log of the data, we found that moving to scapular dyskinesia and then serratus anterior paralysis, the scapulohumeral rhythm was increasing in each pathology. And now, using this information, the hope is that we can actually take the scapulohumeral rhythm, measure it in clinic, and help with the diagnostic process of these incredibly complex scapular pathologies. Another area of a shoulder pathology that we're interested in is adhesive capsulitis. And this is a problem of the capsule that surrounds the glenohumeral joint. It gets abnormally thickened and inflamed, can occur spontaneously, but it can also occur after surgery. And these patients have a real problem of their shoulder, unable to move their shoulder. It's painful, it's stiff, they can't elevate it, externally rotate. It causes a major issue. And often these patients have delayed diagnosis and therefore delayed interventions. So DDR is helping us to really understand adhesive capsulitis as well. As you can see in this normal DDR, the glenohumeral joint is moving nicely. The humerus is elevating within the glenohumeral joint. But in the adhesive capsulitis patient, it's almost as if the glenohumeral joint is fused and all the motion is coming from the scapulothoracic articulation. I think that's fascinating. So when we're taking various cohorts of these patients, we found that the SHR was also very different when examining the dynamic imaging. Again, helping us make those interesting diagnostic decisions, hopefully diagnosing patients earlier so that we can get them back to motion earlier as well. What about massive rotator cuff? This is a problem where typically patients need a lot of workup. They need, examination, imaging, MRIs, expensive workups to really understand what's going on. An X-ray, static X-ray may look like this. The patient has a massive rotator cuff tear, which was MRI confirmed. But on the X-ray, it actually looks like a relatively benign image. The shoulder is well reduced. It's appropriately located in the glenoid. But when taking this same patient, doing dynamic imaging of this patient, you can see that humerus, he's unable to elevate the humerus, and the humeral head is subluxating and superior escape is what we call it. The patient has a massive rotator cuff tear. And we can tell that even without an MRI, which I think is fascinating. So again, this is another patient with the same problem. Patient is what we call pseudo-paralytic. They're unable to move their arm because of a massive rotator cuff tear, which you can't tell from a static radiograph. Now, another field within the rotator cuff tear problem is examining how patients are doing after an intervention, particularly surgery. One type of surgical procedure that we do a lot of is an arthroscopic lower trapezius transfer to help with patients who have a massive rotator cuff tear, to help with their external rotation and also bring down the humeral head because it's to stop it from escaping superiorly. Now, this is a patient who's had that surgery, and you can see that the motion is restored both in external rotation and also abduction. And DDR is helping us to understand how a patient has done after surgery as well. What about shoulder arthroplasty? This is an area that's been changed the field of shoulder surgery over the last decade or two. But we need to still improve. And I think one way dynamic imaging is helping is that we can see that these patients, although they have reasonable motion with the prosthesis in place, you can see a lot of that motion is actually coming from the scapula moving and not at the glenohumeral joint. And that's somewhat limiting the motion and them getting past around 90 degrees. Now, different patients who have similar surgeries, both reverse total shoulder arthroplasties, these patients have excellent range of motion. They have good range of motion from the scapula, but also from the glenohumeral joint, which is where we did the surgery. And what we're trying to understand, and what DDR is helping us understand, is what makes these patients different to the previous patients in terms of preoperative factors, but also, are we doing anything in the surgery that we can modify that will get these patients a better outcome? And DDR is allowing us to actually understand that process. So I was hoping, John, to be able to take you through a quick case study of how DDR has helped us. And this was a patient, a 22-year-old male with recurrent posterior instability. And they came to our clinic, reported over 100 dislocations, daily subluxations of the joint, felt like their shoulder was popping in and out, a lot of pain, regularly, getting up to the 9 out of 10 range daily pain scores. And in terms of how their shoulder was functioning, they felt that the shoulder was only functioning around 20% of a normal healthy shoulder. So clearly a big problem for this patient. So when we took static x-rays, you could see that this patient, because they had a seizure disorder, had a pacemaker type device helping them with that seizure disorder. But in the shoulder, from previous shoulder surgery, the patient had had a posterior bone block procedure that was trying to keep the humeral head within the glenoid. But unfortunately, as you can see on the CT, there was a lot of bone resorption. There's previous anchors from rotator cuff repairs and labral repairs trying to hold the shoulder in place. But it's only until we took dynamic imaging, we really understood the process that was going on here, that the patient was actively dislocating or subluxating quite profusely posteriorly, and that bone block in the posterior aspect of the shoulder was not really holding that shoulder in place. And that was helping us understand the dynamic process that was going on that we weren't able to understand from a static imaging point of view. And also helped us immensely with trying to construct a good treatment option for this patient. And actually, we just published in the last week or two this case report that has really helped us understand these patients with posterior shoulder instability that are frequently misdiagnosed and difficult to treat. So I'm sure we'll hear a ton about artificial intelligence in this meeting, and I think it's one of the areas that's really changed the game in terms of radiology, MSK imaging, and also we're trying to apply it to dynamic digital radiography, mainly because doing manual measurements is time consuming, it's inefficient, it's not the most the best way that we could really integrate it into a clinical workflow. So I really think the future of this is going to be artificial intelligence, so we can automate a lot of this process to help us make those decisions. So we constructed a study with the help of Konica's engineering team, and we included a training data sample of 447 images from about 60 patients. We augmented these images. We added a lot of noise, rotated the images to try and build up this sample. We tried to extract all the features of interest that we were trying to look at. We then built a convolutional neural network, put all of this data in, and we were able to output a model that actually did a really good job from a preliminary point of view. You can see here it was trying to predict all these different angles throughout the arc of motion, both from the scapula and the humerus. We looked at how these measurements compared to our manual measurements at 30 degrees, 60 degrees, and 90 degrees. And it did a really good job. And since then, we have tried to tweak the model to actually work off the lateral border of the scapula, which is more predictable in terms of its location. And we are actually working on that study right now to hopefully integrate these results, validate them, and bring them into the clinic setting to help us automate those measurements, so we do not need to individually make the measurements at every single angle. So, a lot of promise. I think this is where the future is. Still some work to be done. So where are we going with this? I think I've talked about how useful dynamic digital radiography is in terms of our clinical experience. I think there's a lot of work that we still need to do to optimize it in the clinic. I think it's changed the game for the way that we understand these very challenging pathologies, and even patients who have dynamic processes that we can't observe on static modalities. One thing that I think is really important to say is we bring up these images for patients in clinic, and patients love seeing their own imaging. They totally understand where the problem is immediately. It doesn't require a lot of explanation. They trust us and their pathology and our diagnostic decision making immediately. And we've had patients understand their rehab and stick to their rehab, be compliant with their rehab, having seen it in person. So I think that's also fascinating from a patient education point of view. From a research point of view, we now have 15 pending publications in the field of image analysis, artificial intelligence, and also novel applications to shoulder, and we're looking at other extremity pathology, other upper extremity pathologies, and we even have spine colleagues within our department starting to work on the spine and the lower extremity. I wouldn't be able to do this presentation without my the research team that I'm working with. Particular thanks go to Dr. Eric Wagner and Dr. Michael Gottschalk at Emory, who have led the charge on this whole evolution and integration into our clinical practice. Our research team of Hayden, Anthony Samir, and also a team at Konica, John and Takuya, who is working on this in Japan, and wouldn't have been able to do any of this without all of the team. So I wanted to thank you so much for the opportunity to present, to discuss my clinical experience in Brazil. And I wanted to, open up the debate for, any questions, thoughts, and where we're going from this. So thank you again for the opportunity. It's been a pleasure. And what do you think, John?
Thank you so much. It's fascinating. You guys are clearly leading the world in terms of upper extremity clinical use and research with DDR. It's really interesting how much work you've been doing.
Yeah, thank you.
If you, some questions that strike me is at the very beginning you talked about the role of the technologist in acquiring the images and the like. Is there a lot of training? Was there a big transition to start the use of DDR, or how did that go?
Yeah, so there was definitely a little bit of a learning curve. Once we implemented the machines, we had to train the radiographers on how it worked, the positions that we wanted to acquire the images in. We actually made a training sheet so that the trainers could also train other trainers to work and acquire these images for us. We have discussed back and forward with our trainers in our department who work on the same floor as us. There's a lot of cross-pollination of ideas and communication between the radiographers on this because it is so novel. Mm-hmm. And I think once we were past that learning curve, it's been working incredibly efficiently and smoothly. We also have patients, obviously, they don't know how to perform the images. Obviously, the patients probably have never done anything like this before. So we have videos that actually show the patients what position to get into, how to move their arm, how to stay still. Because, traditional imaging with patients holding their breath and staying in the same position is it's very different to that. So, a bit of education for the patients when we see them, but they get it really quickly, and it's been pretty smooth.
Interesting. And what about on the clinician side, for you to interpret and understand the images?
It's like no additional work burden or no additional places that we need to pull up these images. It all goes directly into our packs where we would be viewing our static images just like any other patient before DDR. So it really hasn't been any additional work or burden for the clinician, and it's not difficult to interpret. I mean, people who don't have any shoulder knowledge or any imaging knowledge are easily able to understand how this works and how the shoulder's moving. So, you know, there wasn't any learning curve from our point of view. So very smooth again. Yeah, it's been good. I did have one question for you, actually. Obviously, a lot of our work at Emory has been at upper extremity, and, you know, we're doing a lot of spine stuff now too. Did you have any thoughts on, you know, orthopedic and also non-orthopedic uses of DDR and where we're going and how we're doing on that front?
Yeah, so DDR is about 10 to 15 years old in terms of the research evolution of the technology. Originally developed in Japan for chest imaging. And so there's a large body of research out there focused on thoracic applications of DDR. Currently in the product, there's the acquisition piece itself, and then there's a suite of AI and advanced applications that help quantify, say, diaphragm motion, even going as far as quantifying blood flow to the lungs during the cardiac cycle. So trying to diagnose pulmonary embolisms and any blood flow disorders in the chest as well. So there's a lot of interesting research being done in thoracic applications. With the technology now being rolled out on a mobile platform, that opens up a whole new realm of possibilities. Getting this kind of dynamic information at the bedside, both in the chest and for other applications. So.
Yeah, I mean, it's fascinating. I think there's so many opportunities that it's...
As you mentioned, with because it's not fluoroscopy, with the physician then not being required to be in the room, it opens up the door to doing things like a sniff test for diaphragm, you know, relatively simple exam, but then also doing more complex things like a swallow study or a hysterosalpingogram. Those kind of traditional fluoroscopic exams are now being, a lot of clinics and doctors are trying to use DDR to do the same kind of imaging, which is pretty exciting.
Wow, that's great. Did you have anything else that you were curious about?
On the AI and the advanced application front, upper extremity, you talked a lot about the work that's in the pipeline for the shoulder. Are there any other applications where you think more advanced analysis could be helpful?
Yeah, so we have started doing a lot of taking a lot of dynamic imaging on the elbow, the wrist. We've also looked at the scaphoid, smaller bones in the hand. And one area that we were interested in is, you know, looking at non-unions, which is where the bones have not healed for a variety of reasons. And actually, the dynamic imaging is very important in that position because you can actually stress the bone that may have not healed and understand how well healed it is, or how, you know, how if it's not healed at all, and that can help us understand and make clinical decisions as well. You know, if dynamic imaging shows that the bone is not healed at all, that means we need to do another surgery. It means we need to do you know, try something new. And you don't get that information from an X-ray, a CT, even an MRI. Obviously, those images will show you the other structures, soft tissue structures in the case of an MRI, and the CT will give us a three-dimensional imaging. But to actually see how something changes dynamically under stress is really important, because often we do use fluoroscopy in surgery, but you don't want to be taking a patient to surgery to then decide what you need to do. You know, there's a lot of cost associated with that. There's a lot of other problems associated with making a game time decision in terms of getting patients' consent, getting patients' buy-in, getting rehab set up on the back end. Like, we want to be making decisions in clinic so that we can plan things appropriately too.
And as you mentioned with the shoulder arthroplasty, trying to make that right decision in the clinic so
Right.
that you can do the right procedure and then follow it up. I think that's a fascinating topic that you mentioned, discussed a little bit.
Exactly.
I assume we're waiting for more data to be
Yeah.
collected on that
Yeah.
to see the specific role of DDR in follow-up of patients.
Exactly. And another thing on that note is occasionally we do have small fluoroscopy machines in clinic, not as common, but that is seen in some clinics. But that is, as we talked about, it can totally change the workflow of your clinic. Often we're talking about clinics that have, you're seeing up to 50 patients in a clinic, and you're bouncing between rooms, trying to make have discussions with patients, trying to make as many decisions as possible so they don't have to come back and see you. So the least number of interruptions, the least number of things that we need in order to get through a busy clinic so we can see more patients it is crucial. So that's just another kind of more nuanced version of having that clinical experience and really integrating it into the clinical workflow, I think is really important.
As you mentioned, when the patient comes in, gets imaged, you've reviewed the DDR, you have a good idea of what's going on before you even see the patient.
Go into the room.
Really helpful.
That's right. Yeah. Perfect. Cool. Well, I'm looking forward to talking to the rest of the audience later on at the meeting. I'm excited for that. And yeah, once again, thank you so much for having me, John, and rest of the Konica Minolta group. It's been a honor to be here, and I'm very excited to tell you about how useful this technology has been in our clinic.
That's great. Thank you very much. We're very excited to see the continued work that you guys are doing.
Thank you.
Great.